You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is August 29th, 2025. Our topic today is Approaching Diagnosis, Thinking Like a Bayesian. This is presented by Dr. Marcus Shaker, a professor of pediatrics and medicine at the Geisel School of Medicine at Dartmouth College.
Thank you for saying something. All right, so today we're going to talk about how we approach diagnosis. No, I'm not going to repeat the whole thing again. You're off the hook there. But you can see that the slides kind of fit what we're talking about. Okay, and so I hope that didn't distract you too much, and you were able to kind of think about how you'd approach this kiddo and whether you would want to do testing or not. And so let me then ask you if your ideas of testing change if his last test was in 2012 and 2016. So how many people would? Well, let me just ask: how many people would want to test this kid, or do you think the clinical history is enough?
I would say that the clinical history is enough since he had a recent exposure in the last 3 months, and I don't think testing would change my management.
Okay, how about this? How about if I tell you that his last test was like almost 10 years ago? Does it change it for you? Does it make you think twice? It makes you think differently, maybe, right?
Yeah, it makes me think twice, but it still had a reaction 3 months ago, so.
Okay.
Yeah, it makes me think twice, though, for sure.
Yeah, that's how.
It's likely to outgrow you. I think I would
Right.
agree with Colin.
Right, exactly. You got it. He's 16. He's not likely to outgrow it. He had a recent reaction. He's highly sensitized. So why do we keep testing, right? You guys got this. You're thinking like a Bayesian. You what I just heard you say is what came before is going to help inform what comes next, right? And so that's kind of how I approach this. And so we're going to talk a little bit about that idea. That idea of how the clinical history informs our thinking and informs our testing, and the testing is secondary to our clinical history. And this is discussed in the JTF parameters. If you haven't checked out the JTF site, it's a great site, allergyparameters.org. You can access full text of all the parameters, and there's more coming. I like to step back and talk about how I approach guidelines and how I approach my patients. And so when we think about guideline care, guidelines have to consider all these features, right? Certainty of evidence, acceptability, equity, cost effectiveness, resources, patient preferences, and evidence certainty rigorously evaluated by the JTF is high, moderate, low, or very low, considering all the sort of things that you consider, trial design, risk of bias, confounding, publication bias, all that good stuff. Certainty of evidence really drives the strength of recommendation, but there can be other features such as strong preferences or equity or pharmacoequity that can kind of shift it. Nowadays, thankfully, many recommendations are issued as either just strong or conditional, in favor or against. And with a strong recommendation being kind of an indicator for policy potentially, and a conditional recommendation being a signal for shared decision making. This was the 2020 peanut allergy diagnostics parameter, and it very much kind of goes along what we were just talking about. This idea of what's the pretest probability and how that informs testing. So we did a systematic review and meta-analysis, and we looked at testing characteristics. And the test case here is peanut, but this applies to anything you're thinking about in food allergy, or in medicine in general, or even in life. So this looks at the skin prick test at 3 millimeters, and you can see the sensitivity and specificity as outlined here. Pretty sensitive, not terribly specific, which you all know. And then the likelihood ratios, right? Likelihood ratio being sensitivity divided by 1 minus specificity for the positive likelihood ratio. We also looked at this for the diagnostic operating characteristics for testing for specific IgE, for ERA H2 at a cut point of 0.35. We also looked to see whether any of these tests were predictive for severe reactions, and kind of showing you what this looks like. Well, when you're looking at any test, you want to ideally minimize false positives and maximize true positives, which is exactly what the receiver operating curve is showing you, right? You know, a worthless test at flipping a coin are increasingly valuable tests. This all relates to your classic 2x2 table. And the 2x2 table kind of on the x-axis with the presence or absence of disease, on the y-axis with whether or not the test is positive or negative, realizing that sensitivity means that the test is positive in disease, and specificity means the test is negative in health. Now let's just think about that for a minute. Sensitivity is positive in disease. If I knew the patient had a disease, I wouldn't need the test, right? Specificity is negative in health. If I knew the patient didn't have disease, then why am I doing a test, right? That's just to illustrate that sensitivity and specificity are test characteristics. But what you really care about is what's the likelihood of disease if the test is positive, and what's the likelihood of health if the test is negative. Those concepts describe positive and negative predictive value. So when you're reading in columns on this table, you're reading sensitivity and specificity. That's important to know, because without sensitivity and specificity, you can't calculate positive and negative predictive value. But what you care about as a clinician, what I care about as a clinician, is the PPV, NPV, right? And PPV, NPV are properties not just of the test, but they're also properties of the likelihood of disease prevalence in your population. And that's where it gets slippery, and that's where it gets tricky. Okay, so let's take our case just to drive home the point that you all just made. Jeremy, he's got a recent clinical history. If you're gonna just look at what I showed you, the cut points at 3 millimeters, you've got a sensitivity of 97% and a specificity 46%, a likelihood ratio of 1.82. You already know that he's got at least a 95% chance of having a food allergy. So if you wanted to mathematically demonstrate why you don't need to test this person, okay, you could say, okay, I've got my 2x2 table. I'm going to start down here in the lower corner with 100 patients. My pretest probability is 95. I'm going to do the math. That's 95 times 0.97, 92. You just run through the math. And then as you read across the table and do the math, after you filled it in, you come up with a PPV of 96.8%. Well, you started before you even tested 95%, and you have a negative predictive value of 40%, which is not all that valuable. So that's why you don't need to test this child who just had, or this young adult who just had a recent reaction. Just to illustrate this idea that what you decide it varies by the pretest probability by your prevalence of disease. Here's another case. Just made this up. A 15-month-old child wakes up from a nap, but 10 minutes before the nap, he'd had a peanut butter, and he's got a virus. He's got a viral illness. Okay, I don't know whether this kid's got a peanut allergy or not. I mean, I don't know. It could, possible. You know, he's got. I'm flip a coin. I don't know. I mean, 50%. You know, let's just say that, and then let's run through the exercise again. I filled in the numbers for you here. And as you run it through, you get a PPV of 64% and you get an NPV of 92%. That NPV to me is useful. You know, that's a useful NPV to me. That helps me understand what I want to do. So determining on the test can help me if I need the test. But if I don't need the test, it's not going to be all that helpful. This was translated into the Fagan nomogram. This is from the parameter, and these nomograms are kind of placed there, and you can actually use these if you know the likelihood ratio. And you don't actually have to know the exact pretest probability of the disease. You can estimate it. And what's interesting is you can see that as you run this through on a low pretest probability of 2% with a likelihood ratio of nearly 2, you get a post-test probability of 4%, right? But it's just interesting, like if I take a child who's got a low likelihood of food allergy, and I'm convinced for whatever reason, often because of, the need to try to use allergy testing as some form of cognitive behavioral therapy, for which there is an argument, okay, that we can talk about, but you got to be very careful. But if you hit the jackpot and you got a positive test, psychologically for a patient and a family, they're not thinking that I've got a 4% chance of an allergy. Now they're thinking I've got a 100% chance of an allergy. So we think as human beings as dichotomists, but the world is Bayesian. And so that's the struggle we always face with testing and trying to explain testing. And you can see as the likelihood of disease goes up, the test becomes more valuable, right? So that's that. So let's ask some questions about severity. So which statement is most accurate about severity and thresholds? Severity is completely unpredictable. A patient with high threshold will experience a mild reaction. Skin testing predicts severity. A severity and threshold may both be variable and relate to multiple factors, although in many patients, they can have fairly consistent severity and threshold over time. So I know that I'm not dealing with rookies here. I know you all have probably taken a few of these multiple choice exams in your careers, and I know you probably noticed that the longest answer is D. And so that is actually the correct answer here. But what can we say about severity and thresholds? There's a little bit to talk about here, actually. It's an evolving landscape. You know, the 2020 grade parameter suggested against the use of skin prick test, SIGE, or components to determine reaction severity, but it was a low evidence conditional recommendation based on data that's now 5 years old. And there are novel methods, BAT, epitope, multimodal methods that may be useful, may show some benefit down the road, but will probably take some AI as well, and some fairly complicated mathematical models to really be valuable. Clinical severity and thresholds, and that's because there's a lot of factors, you know, that drive this. And ultimately, the decision to test or not to test is likely one that's shared, and it's going to depend on what you're going to do with the information. So I like this study. This was a study looking at thresholds and severity. This was by Patel and colleagues. They looked at different food challenges and looked at individual participant data from over 3,000 patients undergoing challenges in a variety of different studies. And they found that severe reactions were uncommon at low thresholds. Okay, but still 5% of patients reacting to less than 5 milligrams of peanut had anaphylaxis. Okay, so that's not but not common. What I tend to worry about when I'm doing threshold challenges is not the severe reactions at the low thresholds. That doesn't bother me at all. What I'm not really crazy about is a severe reaction at the high threshold, you know, because that can happen as well. And this idea that you can still have, even though you're establishing somebody with a high threshold, they can still have a pretty severe reaction. I mean, threshold and reaction severity, while somewhat related, are distinct constructs. Okay. This is just a figure that was in the 2023 parameter showing the fact that severity and can be related to allergen-related features, how things are processed. They can relate to host factors. Did you take an antacid or did you exercise? And they can relate to outcome. Were you adequately treated with epinephrine? I like this data from Slapnikar and colleagues showing the reproducibility of reactions in recurrent anaphylaxis with a Fleiss kappa score of 0.94, which is fairly reproducible. Really, I'm showing you data that although, you know, the past reactions can predict future reactions, there are caveats to that. This is one. So this is the TRACE study. Looking at sleep deprivation or exercise and how this impacted the threshold. In one of these TRACE studies, there were two. This was the 2024 crossover challenge study in adults with peanut allergy. They found that sleep deprivation increased reaction severity by 50%. We actually have a paper coming out on how sleep interacts with allergy, which is coming out in practice. So are thresholds stable? Well, for those of you who are still on Facebook, which I suspect is none of you, the answer would be it's complicated. You've got this biological construct with, you know, high affinity IgE and impermeability in the gut. You've got these factors of exercise, illness, sleep deprivation, booze, medications, and you've got these modifying factors like oral immunotherapy and anti-IgE that all impact it. So, you know, although generally stable, you know, you've got to use your clinical context here. In the study by Patel, thresholds varied by 3 logs, although we're limited to half log variations in 72% of individuals. Why does this matter? Well, it matters because we're doing threshold challenges now with omalizumab, right? Somebody's coming in, I'm putting them on some omalizumab. put them on a few months, and I'm saying, hey, let's come back and see what your threshold is. I need to be clear when I'm doing those threshold challenges that just because you have a high threshold here doesn't mean that's always going to be the case. Chances are that's going to be pretty sticky. But if you're having a bad day, or you exercise, you took an antacid, or you're sick, then your threshold can change. So people need to understand kind of what's going on there. I'm going to turn to one of my favorite topics. This is a case where you're counseling the family of a 7-month-old breastfed infant on food introduction. And you could even, if you want to put yourself back to 2020, if you don't want to be in 2025, but I'd prefer you be in 2025. The infant has severe eczema. He's got a brother with milk allergy who was hospitalized for anaphylaxis last year. The family's worried. Mom's in the ER room, doc, but they're wondering, should they try to screen for peanut or just try it at home? So how many people think that you should screen for peanut in this kid? Severe eczema, brother with milk allergy and anaphylaxis. Anybody want to put some tests on? Are you all still there?
Yeah, we're here.
Okay.
I would not screen and kind of talk to the family about it. I'm with one of my other co-fellows, and we would both.
I think you could go both ways.
I would recommend doing it at home.
I like your thinking. In fact, I think I'm going to take you all with me on all my talks. We can do them like podcasts. This is cool because you guys are spot on. So let me review some of the evidence here. So this was a 2016 systematic review meta-analysis. A bunch of studies, moderate certainty evidence that early introduction reduces both egg allergy and peanut allergy. So I don't think that's really in question. Families have these trade-offs when it comes to screening. They can potentially avoid the risk of a first peanut reaction at home with skin testing, but that's going to risk overdiagnosis. The first peanut introduction in a supervised challenge can risk a delay in that challenge. I mean, I bet in your clinic you probably couldn't get somebody in for a supervised food challenge for at least a few weeks, maybe a few months. You could give the first peanut at home. That would optimize the benefit of early intro, also allow the family to use very small amounts of food introduction, but you could risk a reaction. But screening in the clinic with observed intro is probably not worthwhile unless the family is willing to trade the equivalent of nearly 50% of 1 year of life when you do it in pharmacoeconomic terms to have a first reaction in clinic versus at home. There's some other issues. So the data from Volterra's suggested that evidence screening creep, evidence suggests screening creep is common. They looked at 84 infants and only 48% actually met screening criteria. Poor access to screening procedures can delay introduction. Only 50% of those with a mid-range test for which challenge is recommended were even offered OFC. The rest were just told to avoid it. And partial guideline implementation. This is a Ruchi Gupta study, nearly 2,000 pediatricians, 64% were aware of those who are aware of the guidelines, use them incorrectly. That's to say that people are doing specific IgE tests, getting a positive, and then stopping there, which you're basically saying is this is the kid is high risk. I might be able to make a difference if I introduce it early, so I'm not going to do anything. Right, so that's not what we want. So, and then we've got to think about the patient values preferences. They're not a monolith, and they're driven by fear and hope. And so that's where we can do some of our greatest work, right? So we can educate about what the risks really are. I was just having a conversation with one of our medical students, Becca, and we were talking about the fact that that parents are risk managers, right? That's what parents do. Pediatricians and allergists, we're the risk managers for the risk managers, right? And so if we set the expectation of zero risk in life, we do somebody a real disservice because life is not a risk-free game. But if we can help contextualize risk for people in everything we do, then we can help them, learn to live with reasonable risk in life. And fatal food anaphylaxis is rare. It's much less common than the risk of accidental injury or car accident. It's on the order of lightning strike. And there's never been a published first fatality from a food introduction at home. Resource allocation is important. This is getting to be older data. This is back in 2018 when we modeled the U.S. approach at the time of screening high-risk kids with the approach everywhere else in the world. And we found a vast waste, $654 million from a societal perspective, and overdiagnosis of over 3,000 cases of peanut allergy. In addition, 25% of kids with peanut allergy were completely missed by the approach. When you look at issues of equity, there's clear socioeconomic disadvantage in access to these procedures. There's clear socioeconomic differences in historically marginalized populations and the burden of food allergy. And we already know that across society, the estimated cost per child, and this is in 2013 dollars, was nearly was just over $4,000. And we know that it's not feasible. You know, if you were going to screen all these kids who are high risk, and you've got over 640,000 infants at risk annually, and you've only got 6,000 allergists in the U.S., and only half of them offer food challenges, the math just doesn't add up. You just can't do it. This is a Matt Greenhawt study from 2018 looking at caregiver preferences. 61% had no concern for their kid developing food allergy in the first place. 54% thought early allergen introduction mattered, and most were unwilling to even go risk assessment or food challenge in the clinic. Shortly after LEAP got published, you're looking at the early introduction of foods in Australia without a screening approach. They found that nearly 9 in 10 infants were consuming peanut by 12 months compared to 3 in 10 infants before and the decade before. But it probably, subsequent data from Australia probably tells us that it's not enough just to eat early. You've got to eat early and often. So it's not just enough to eat once. You've got to incorporate it into the diet a few times a week. So screening may prevent or delay some index reactions, but may overdiagnose, and preferences really kind of drive this. And this is an opportunity for shared decision-making. Shared decision-making where the clinician is the expert in the science, recognizing the patient and their family as the experts in their own preferences and values, taking time for active listening, and helping people understand what the trade-offs are. With all this in mind, it sounds like you all have read this. This was the consensus approach we published back in 2021. This was a consensus between the Academy, the College, and the CSACI, and it really stated that while peanut skin testing or specific IgE are things that could be offered, they're not required. And in fact, I think we're even getting further along the path here to really maybe even discourage this approach for patients who might just be able to introduce a little bit of peanut at home. Okay, so I'm going to give you, I think this is the last example here, and then we're going to have time to kind of pause and maybe take some questions. This is a little baby, 18 months old. He was treated for bilateral ear infection 12 months ago. He had a rash on his face, his chest, his extremities after 4 days. The amoxicillin was stopped and the rash improved. His parents were told he was allergic to amoxicillin to avoid all penicillins and probably cephalosporins. And the patient subsequently received a course of azithromycin for an ear infection. So how to approach this child was addressed in the 2022 practice parameter on drug allergy. This had a lovely update on a lot of topics led by David Kahn. Had clarification on how the clinical history can help us provide phenotype. It had discussion on preferential utilization of drug challenges over skin testing in many cases for diagnosis, emphasis on proactive penicillin delabeling, discussion of the need to prevent unnecessary avoidance of safe antibiotic alternatives, and even updates on non-penicillin agents, including aspirin and chemotherapeutics. So a very wide-reaching document. Okay, so I'm going to go to my podcasters here and ask you, Carlos has been diagnosed with a drug allergy. How would you manage him? No additional management needed, just avoid penicillins. It doesn't have to be that complicated. Schedule a skin testing visit and test him to major and minor determinants, ampicillin by prick and intradermal. Schedule skin testing for Pen-G and pre-Pen. Schedule a visit for direct oral challenge to amoxicillin single dose without skin testing. Schedule a visit for direct oral challenge to amoxicillin 5 to 7 days without skin testing. Or avoid penicillins for now and consider evaluation after another 6 to 12 months when you're done with your fellowship. What do you think?
D, schedule visit for direct challenge.
Yeah, I agree with that. D.
You're going with D as in dog?
Correct. Yeah.
You don't want to do the 5 to 7 day course.
I sure don't.
No.
I sure don't either. Because one dose is enough. You'll see the delayed reaction with one dose. We don't want to encourage antibiotic resistance. There's data that those longer courses don't actually provide you any benefit. This is from the Van Gist study. They looked at 132 patients and found limited value for those multiple day challenges. And this is the Mill study on the headline here, showing the value of direct oral challenge. 94% of kids were tolerant of amoxicillin, and some had delayed reactions, but 95% did just fine. This is data that Kim Blumenthal was involved in, looking at the sensitivity and specificity of skin testing and serum-specific IgE. Poor sensitivity for both, with IgE and skin prick testing ranging from 20 to 30%, although both were pretty specific. Negative in health, pretty specific, like water. So let's take the history and the evidence again, kind of go through this exercise. We have our patient. He had this macular-papular rash. We have the Mill data. 94% of such kids are going to tolerate a direct oral challenge. We've got the data on testing, sensitivity 30.7, specificity 96.8. Let's plug in the numbers. Let's do the math. And as we run this through, let's see what this looks like. We know that the 940 out of 1,000 patients are going to be able to tolerate it. And as we run this through, we see that with placing the test, you only get your negative predictive value up to 95.6%. And your PPV is only 38%. So you went from a negative predictive value of 94 to 96. Probably not worth putting the tests on. So again, the idea of your pretest probability. Let's change the situation. This is a 54-year-old woman now who presents with urticaria, angioedema, and wheezing. And hypotension 10 minutes into an ampicillin infusion, but she was also septic. She's got a high pretest probability, I would say, of at least 50% based on her history. And so we could plug this in again, and as we do this, we find that the skin testing is actually more valuable. A skin test positive predictive value, when you run the numbers through the 2x2, comes to 91%. Versus 50%. So in this case, I think skin testing would make sense, and the practice parameter would emphasize that. The patients who have a high-risk history should get testing. A general phenomenon that you see in any kind of testing, Bayesian testing, is that as the prevalence of allergy goes up, so does the positive predictive value, and as the prevalence goes down, so does the negative predictive value. So are adults just big kids? Well, these strategies also work well for adults, although adults may be higher risk. Adults without reactions for more than 1 to 10 years, limited skin reactions without any high-risk features, direct oral challenge is certainly an option. This was a study by Shahzad Mustafa and colleagues looking at an RCT comparing skin testing to direct oral challenge. They had a mean age of 35 years old. 87.5% of the patients were skin test negative and tolerated amoxicillin, but 96% tolerated direct oral challenge, showing you that the testing isn't always as specific as you'd like it to be. These are the contraindications, the red flags. Anybody with a scar, anybody who's had severe culprit anaphylaxis, vasculitis, exfoliative dermatitis. These are all generally red flags to oral challenge. These are just some of the consensus-based statements from the drug allergy practice parameter, suggesting penicillin skin testing for patients with a history of anaphylaxis or recent reaction, against routine multi-day challenges, against skin testing prior to direct oral challenge for kids with benign cutaneous reactions, and suggesting that direct oral challenge can be considered in adults who have benign cutaneous reactions. This is a helpful review from the parameter 2, looking at cross-reactivities of beta-lactams. Importantly, anyone with non-anaphylaxis who's got a penicillin allergy can get a cephalosporin by direct oral challenge, or just you can just administer it, not even by direct oral challenge. You can just prescribe it. Anybody who's had a verified cephalosporin allergy can get a penicillin by direct oral challenge. But for patients who've had a cephalosporin allergy, it is recommended that they have penicillin skin testing prior to the administration of penicillin if they had a history of anaphylaxis to the cephalosporin. Again, it comes down to shared decision making for a lot of these conversations, where we value the patient as the expert in their own values and preferences. As the line from Hamilton goes, it's important to talk less and smile more, and give people a chance to kind of explore where their values are. And sometimes this takes more than just one visit. You know, most people don't buy a car or a house in one visit. It's okay if you need more time to kind of consider things. Validated patient decision aids can be very helpful in this process when available. So to wrap up, I think the points I've tried to make when we think about allergy testing is that human psychology tends toward dichotomy, but testing is Bayesian. Sensitivity and specificity inform likelihood ratios, and likelihood ratios translate to help translate pre-test probability to post-test probability. It all comes down to kind of meeting the patient where they're at. And I think that is all I have for you today.